You know, if you break your arm, the diagnostic process is, well, it's essentially engineering.
Right, it's very binary.
Exactly. I mean, an X-ray gives you this clean, high-contrast answer. You look at the jagged white line on the film, and it's either broken or it's not.
Yeah, there's no real ambiguity there.
But the moment you step into the world of gynecological oncology, that comforting diagnostic certainty it just completely vanishes. You are suddenly flying completely blind.
Oh, absolutely.
Yeah.
I mean, it is the definition of diagnostic muddy waters. The tools we rely on for almost every other system in the body, they often just hit a brick wall when it comes to the female reproductive system.
And that's exactly why we're here today. We are looking at a massive stack of sources for you. We've pulled current clinical guidelines, a whole series of comprehensive oncology reports on gynecological malignancies, and the highly anticipated 2026 Regenerative Medicine Watch List.
That's a lot of material to get through.
It is, yeah. And our mission today is to answer a really critical question for you. How do clinicians currently screen for and diagnose pelvic and vulvar malignancies? And how is the explosive science of something called exosomes completely revolutionizing this entire process? Okay, let's unpack this. Because if we really want to understand why this new exosome technology is so revolutionary, we first have to understand just how archaic our current tools actually are.
Yeah, archaic is definitely the right word for it. The contrast between the current standard of care and where the science is heading over the next few years is, frankly, it's staggering.
I was reading the section on vulvar cancer, and I literally had to read it twice just to make sure I wasn't misunderstanding the medical jargon. According to the guidelines, there are actually no standard screening tests for vulvar cancer for asymptomatic people.
None at all.
Which is wild to me. I mean, we have mammograms for breast cancer, we have pap smears for cervical cancer. So if there is no swab and no routine blood test, how on earth do clinicians actually catch this before it's too late?
Well, that is the incredibly frustrating part of the current landscape. Because there is no routine screening protocol for someone who feels perfectly fine, detection relies entirely on the patient noticing symptoms first.
So they just have to wait.
Right.
Huh.
We're waiting for things like persistent itching, localized pain, or a visible structural change. And once the patient flags that, the clinician has to rely on a visual pelvic exam.
Wait, so the diagnostic protocol is literally just looking for it with the naked eye?
Initially, yes. And if the clinician spots an abnormality, they escalate to a procedure called a colposcopy. They use a specialized magnifying device to, get a closer look at the cellular structure of the tissues.
Okay, that makes sense.
But human tissue is largely monochromatic when you're looking for early-stage cellular changes. So to make the abnormal lesions actually stand out, the clinician applies a 3 to 5% acetic acid solution directly to the sensitive area.
I want to pause on that because the notes mention acetic acid and it sounds intense. What is the actual biological mechanism there? I mean, why are we applying acid to find cancer?
It's a fascinating, if rudimentary chemical trick. Acetic acid temporarily dehydrates the cells. Now, cancer cells, or precancerous cells, they have a much higher nuclear density than healthy cells.
Meaning what, exactly?
Meaning their nucleus takes up more space, and they have less cytoplasm, which is the watery fluid inside the cell. So when the acid hits them and pulls the moisture out, the dense proteins in those abnormal cells coagulate.
Oh, wow.
Yeah, they reflect light differently, turning stark white under the colposcope. It essentially acts as a localized highlighter pen for the clinician's eye.
Okay, that makes sense biologically, but it still feels incredibly primitive. And the guidelines say that even if they see these white patches, that's still not enough for a diagnosis, right? They still need to physically take a piece of you.
Unfortunately, yes. A visual change only suggests abnormality. To actually diagnose a malignancy, we have to see the cellular architecture under a microscope. And that requires a biopsy under local anesthesia.
Which sounds painful.
It is. Depending on the size of the lesion, they might do a punch biopsy, that's using a circular blade to core out a small cylinder of tissue. Or they might do an excisional biopsy, which involves using a scalpel to remove an entire patch of skin.
I mean, obviously I know what a biopsy is, but when you lay it all out like that, we're talking about waiting for symptoms to appear,
Yeah.
applying acid to see if cells turn white, and then coring out tissue with a scalpel. And that's just to confirm the cancer exists at the surface.
Exactly.
The notes mention that to see if it has spread, clinicians have to pivot entirely to systemic imaging.
Right, because we have to map the surrounding territory. Clinicians use CT scans, MRIs, PT scans, and sometimes an IVP.
An intravenous pyelogram.
Yes, which uses a contrast dye to see if the tumor has invaded the urinary tract. And then, to check the lymphatic system, they perform sentinel lymph node biopsies. They inject a radioactive tracer or a blue dye near the tumor, wait to see which lymph node the dye drains into first, and then surgically remove that specific node to see if cancer cells have hitched a ride into the immune system.
So it's scalpels, acid, and radiation imaging.
That's the current toolkit, yes.
But here is the terrifying caveat the oncology reports highlight. As visceral and invasive as that whole process is, at least vulvar cancer has visual external cues. Once you move deeper into the body cavity to something like ovarian cancer, you lose even that rudimentary visual advantage.
Yeah, you can't exactly apply acetic acid and look through a magnifying glass at an organ buried deep within the peritoneal cavity.
Right. Reading about how we currently diagnose deeper pelvic masses, it feels like trying to figure out if a house is on fire by looking for a 1-degree temperature change on a satellite map, rather than just installing a smoke detector in the kitchen.
That is a perfect analogy, and ovarian cancer, or OC, perfectly illustrates that limitation. It is the most lethal gynecological malignancy specifically because it acts as a silent killer.
Because it's hiding.
Exactly. Most ovarian cancer cases aren't found when the tumor is the size of a pea and easily removable. They are generally only detected at stage 3 or 4, long after the tumor has actively spread across the organs in the abdomen.
And that's because the early symptoms are things like bloating or fatigue, things that, literally anyone might experience on a random Tuesday, so they just get dismissed. So when a patient finally does present with a suspicious mass on an ultrasound, how do clinicians currently figure out if it's benign or a lethal stage 3 cancer without cutting the patient open?
Well, they attempt to look for clues in the blood. They test for specific protein biomarkers shed by tissues, most notably CA125 and HE4. They take the levels of those proteins and run them through something called the ROMA algorithm.
The risk of ovarian malignancy algorithm.
Right.
But the clinical reports state this ROMA algorithm is heavily flawed. I was looking at the inputs, and it factors in CA125, HE4, and menopausal status. Why does menopause matter when we're just trying to detect a tumor?
It matters immensely because of what CA125 actually is. It's not a protein exclusively made by cancer. It's a protein produced by the mesothelial cells that line the organs in the abdomen and reproductive tract. A premenopausal ovary is a highly dynamic, active environment. Every single month, tissue is growing, shedding, and bleeding. So conditions like endometriosis, pelvic inflammatory disease, or even just a heavy menstrual cycle can cause a massive spike in CA125.
Oh, I see. So for a 30-year-old, a high CA125 might just mean a rough cycle, leading to a terrifying false positive.
Exactly. Whereas for a 65-year-old postmenopausal patient, where the ovaries should be completely dormant, that same spike is a blaring alarm bell.
Right.
But the reverse is also true. In the very early stages of actual ovarian cancer, the tumor might not shed enough CA125 to trigger a positive result at all, giving a patient a false negative.
So the satellite map might show a fire when someone is just having a barbecue, or it might completely miss the fire burning in the basement until the roof caves in.
This raises an important question. How do we build that internal smoke detector? If relying on generic proteins and surgical biopsies is failing us, how do we bridge this massive gap in early detection? To answer that, we have to look entirely outside of traditional oncology and turn to the 2026 watch list on regenerative medicine.
Here's where it gets really interesting, because to solve this diagnostic void, science isn't just trying to build a higher resolution MRI scanner. They are looking at the fundamental mechanisms that cells use to communicate with one another. We were talking about exosomes. For you listening, if you aren't familiar with exosomes, this is the frontier of biology. I've heard them described in the literature as microscopic cellular FedEx packages, constantly being shipped out by our cells to traffic critical information around the body.
Yes, FedEx packages is a great way to picture them. To put some biological parameters on that analogy, exosomes are a specific type of extracellular vesicle. They're incredibly small, only 30 to 150 nanometers in diameter.
That's tiny.
Very tiny. For scale, a single red blood cell is about 7,000 nanometers. Almost all cell types in the human body release them. But what makes them special isn't just their size, it's their structure and their cargo. They have a lipid bilayer, which is essentially a protective outer shell made of fat.
Why does the fat shell matter so much?
Because the human bloodstream is a highly hostile environment. It is filled with enzymes whose sole job is to chew up and destroy loose, floating genetic material to protect us from viruses.
Ah, so it's a defense mechanism.
Exactly. If a cell just threw raw RNA into the blood, it would be destroyed instantly. The lipid bilayer acts like an armored transport vehicle. It protects the highly specific cargo inside, which includes proteins, double-stranded DNA, and regulatory instructions like microRNAs and long non-coding RNAs.
So they are actively mailing secure encrypted instructions from one organ to another. And the regenerative medicine watch list shows that science is trying to harness this. The big push right now is exosome biostimulation, gathering these healing packages from healthy stem cells and injecting them into patients to trigger massive tissue repair or anti-aging effects.
The regenerative potential is undeniable, but, and this brings us back to gynecology, there is a very dark side to exosomes. While healthy cells use them for maintenance and repair, tumor-derived exosomes are hijacked by cancer. The tumor uses this exact same communication network to promote its own survival and spread.
And this leads to a massive contradiction in the clinical guidelines that I found fascinating. The reports state that if a clinician wants to give a patient this futuristic exosome biostimulation therapy for tissue repair, they are strictly required to screen that patient for active pelvic or vulvar malignancies prior to administering the therapy.
They absolutely have to. If you introduce a massive wave of regenerative growth-promoting exosomes into a body that is harboring a silent, undetected ovarian tumor, you could inadvertently throw gasoline on a fire. You could supercharge the cancer.
But wait, if they have to screen the patient for silent cancers before giving the therapy, how do they do that? Do they have a futuristic exosome test for that?
That's the tragic irony of our current transition period. To clear a patient for 21st century regenerative therapy, clinicians currently have to fall back on the 20th century tools we just discussed. They have to run the flawed Roma blood tests, do the visual pelvic exams, and use the ultrasounds.
So we are gating futuristic medicine behind archaic screening tools. That is incredibly frustrating.
It is.
Especially when you read about what the cancer is actually doing with its own exosomes. You mentioned the tumors hijack the network. The oncology reports give some terrifying examples of how this works. It says in ovarian cancer, the tumors shed exosomes carrying a protein called CD44. How does a tiny fat bubble with a protein on it help a tumor spread?
Well, when an exosome carrying CD44 enters the peritoneal fluid, it seeks out normal, healthy mesothelial cells, the cells lining the abdominal cavity. The exosome's lipid shell fuses with the healthy cell's membrane, essentially docking and dumping its corrupted cargo inside.
And what does the cargo do?
That CD44 forces the healthy cell to alter its own structure, breaking down the extracellular matrix. The cancer is literally mailing out instructions to healthy tissue, forcing it to clear a path and build a hospitable nest for the cancer to spread into before the cancer cells even arrive.
So it's preparing the soil for metastasis remotely. That is mind-bending. There's another example in the notes, something called miR215P. It says this is a microRNA carried in exosomes that creates chemoresistance. How does RNA stop a chemical drug from working?
MicroRNAs act as regulatory switches. When a tumor-derived exosome drops miR215P into a neighboring cancer cell, that RNA acts like a computer virus. It binds to the specific messenger RNA inside the receiving cell that normally tells the cell to die when it detects a toxic chemical like chemotherapy.
So it blocks the self-destruct sequence.
Exactly. The microRNA silences that death signal. So when the chemotherapy arrives, the cell just ignores it and keeps replicating.
The cancer is updating the software of the surrounding cells to make them invincible. It's sinister. But here is the massive pivot point in the research. Since tumors are constantly shedding these highly specific, malicious FedEx packages into the bloodstream and other fluids, well, clinicians realized they could intercept the mail. We are taking exosomes from being a weapon of cancer and turning them into our greatest diagnostic tool.
If we connect this to the bigger picture, this interception is the foundation of what we call the liquid biopsy.
I want to push back on this for a second, just to play devil's advocate for the listener. I understand taking a blood draw is obviously less painful than taking a scalpel to the skin for a biopsy. But how can looking at a tiny fraction of floating packages in the blood possibly be more accurate than physically cutting out a piece of the actual tumor and looking at it under a microscope?
It comes down to a concept called tumor heterogeneity. We tend to think of a tumor as a uniform lump of identical bad cells.
Right, like a cancer cell is a cancer cell.
But that's biologically incorrect. As a tumor grows and mutates, it creates distinct neighborhoods of cells. The cells on the left side of the tumor might have a completely different genetic mutation and a different drug resistance than the cells on the right side.
Oh, I hadn't thought of that.
Yeah, so if you use a needle or a scalpel to take a physical punch biopsy, you're only capturing a snapshot of one tiny neighborhood. You might completely miss the highly aggressive subclone of cells growing just a centimeter away.
But the exosomes, they are being shed by every cell in the tumor.
Every single subclone of cancer cells is constantly shedding its specific packages into the bloodstream. A liquid biopsy doesn't give you a localized snapshot. It gives you a live, continuous broadcast of the entire tumor environment. And because of that armored lipid bilayer we discussed earlier, that genetic material is highly stable. We can easily collect it from blood, urine, saliva, or the ascites.
Eocytes.
Yes, the abdominal fluid that often builds up in ovarian cancer patients.
So we're talking about a test that is not just non-invasive, but gives us a complete genetic map of the enemy. And the notes list some of the specific markers they are already isolating. They aren't looking for generic proteins like CA125 anymore. For ovarian cancer, they're finding things like plasma-derived exosomal, MIR47325P, and MIR205. For cervical cancer, they are tracking MIR125A5P. For endometrial cancer, it's MIR15A5P.
It's an entire alphabet soup of highly specific tracking numbers.
It really is. But how do we actually catch them? I was reading about a piece of technology in the watch list called the ICDSE system, and honestly, the science sounds like absolute science fiction. They're engineering red blood cells.
The Integrated Concentration and Determination System of Exosomes. It is a brilliant piece of bioengineering.
Okay, so translating the jargon in my notes here, it says they use engineered red blood cells functionalized with CD63 specific aptamers. What is an aptamer in plain English, and what is it doing to a red blood cell?
Think of an aptamer as a highly complex chemical lock-and-key mechanism. Researchers take natural red blood cells and essentially cover their outer surface with thousands of these tiny chemical locks, the aptamers.
Okay.
These specific locks are designed to snap shut only when they bump into CD63, which is a protein heavily present on the surface of cancer exosomes.
So they're turning red blood cells into a fleet of microscopic garbage trucks covered in molecular Velcro that only sticks to cancer packages.
That is a remarkably accurate way to visualize it. You introduce these engineered red blood cells to a simple blood sample from the patient. The red blood cells sweep through the sample, and the molecular Velcro snags all the tumor exosomes. Then to actually read what they've caught, they pair it with a plasmonic sensor.
Right, the sensor. How does that work?
A plasmonic sensor uses the physics of light. When light hits the surface of the sensor, it creates an electromagnetic wave. When those engineered red blood cells, now heavy with captured cancer exosomes, bind to the sensor, it changes how the light behaves.
And the sensor picks that up.
Yes. The sensor detects that shift in the light wave and amplifies the signal. It allows us to detect incredibly minute concentrations of cancer exosomes quickly, cheaply, and with a sensitivity that traditional blood markers like CA125 could never dream of.
So what does this all mean? For you listening, it means we are standing on the precipice of a monumental shift in medicine. We are finally moving away from the era of painful, localized tissue sampling, away from waiting for a patient to feel pain, away from applying acetic acid to see what turns white, and away from imperfect satellite imaging trying to guess if a mass is malignant. We are moving toward a reality of holistic, real-time tracking of a cancer's exact genetic footprint via a simple, routine blood draw.
It is a crucial paradigm shift. Whether you are prepping for a medical career, trying to navigate the complexities of the healthcare system for yourself or a family member, or simply staying informed on the cutting edge of biology, this matters. Understanding that the future of cancer diagnosis is shifting from managing symptoms after the damage is done to non-invasive, real-time molecular interception, it changes how we view the disease entirely. It means we can catch the silent killers before they ever have a chance to speak.
It's incredible. We started this deep dive in the absolute muddy waters of current diagnostics, where clinicians are forced to gatekeep futuristic therapies behind scalpels and outdated algorithms. And we've traveled to the bleeding edge of regenerative medicine, where nanoscale lipid vesicles circulating in our blood are unlocking the deepest, darkest blueprints of a tumor.
It promises to clear up those diagnostic muddy waters permanently.
It really does. It's like finally getting that high-definition X-ray precision, but on a molecular genetic level. But I want to leave you with the final thought to mull over, building on everything we've just discussed. We now know that tumors use exosomes as their own private postal service to spread instructions and evade drugs. And we know we can now intercept those microscopic messengers in the blood to diagnose the cancer. But if we can map their network, could the very next step in regenerative medicine be engineering our own synthetic exosomes, loading them with a targeted genetic cure, and sending them back to infiltrate the tumor, using the cancer's very own communication network as a Trojan horse?
Using the tumor's logistics against itself. A genuinely fascinating prospect.
Something to think about as this technology explodes over the next few years. Thank you so much for joining us on this deep dive. Keep questioning, keep exploring, and we'll see you next time.